Aujourd'hui de vous présenter la docteure Thais MEGID pour notre conférence mensuelle. Docteur Megid, je vais dire sa biographie en anglais, puis aujourd'hui, sa présentation sera en anglais, mais je suis certain qu'on pourra, si vous avez des questions en français par la suite, je suis certain qu'on pourra faire la traduction. Juste pour vous rappeler, avant qu'on commence, s'il vous plaît, de fermer vos micros, fermer vos caméras, juste par respect pour la docteure Megid. Donc, Dr. Thais MEGID is a medical oncologist specializing in GI malignancies. She completed her medical degree, followed by training in internal medicine and medical oncology at the Syrian Lebanese Hospital in Sao Paulo, Brazil, where she subsequently practiced with a focus on GI cancers. She pursued advanced subspecialty training through a 2.5-year clinical fellowship in GI malignancies at the Princess Margaret Cancer Center in Toronto. In parallel, she completed a 2-year fellowship in quality improvement and patient safety with Veterans Affairs Quality Scholars Program at the University of Toronto as well. Dr. Megid has been actively involved in cancer research and has published in several high-impact oncology journals. She currently practices at the Georges L. Dumont University Hospital Center and serves as an assistant professor at the University of Sherbrooke in Quebec. And today we will be hearing Dr. Megid's thoughts on addressing financial toxicity and quality of life in cancer patients in New Brunswick. So please welcome welcome Dr. Megid, and the floor is yours. So you can go ahead and tell us your story.
Well, thank you so much for the opportunity that you guys are giving me to present our research. That I'm very proud of this project. And I'm so sorry that my French is not good enough for this presentation, so I'll be presenting in English. So I appreciate the presentation. That was much better than I would never present myself like that, but thank you. So I've been working here at Georges Dumont for almost 2 years now, and I've been involved in research before. When I was in Princess Margaret, I was involved in clinical trials. But what I have a particular interest in patient safety and also other projects when it comes to patients' quality of life. And when we think about cancer and the cancer journey, we are always talking about these new treatments and the impact of these new treatments in survival and the new mechanism of actions, new molecules. But sometimes we forget to talk about other domains in the oncology journey, and that includes quality of life and the financial toxicity. And often, we forget about these things. And today we're going to show the preliminary results of our project. And you will see that maybe we should be addressing this issue more with our patients. So hopefully I'll be able to show the importance of the financial toxicity in the patient's cancer life. And hopefully in the end we'll get your thoughts about how do you see this project and how can we improve moving forward. So this research was supported by the Duo Fund. We received a 25,000 grant to do this project. And something you might not know is that 57% of the patients, they worry as much about cancer's financial impact as about dying from cancer. So sometimes we think that patients are worried about treatment side effects and dying from the disease, but sometimes the financial impact of the cancer can impact as much as dying from cancer. So what is financial toxicity? Financial toxicity is everything related to detrimental effects caused by the cancer financial strain. So all the costs directly and indirectly related to the cancer treatment that affects their quality of life and well-being is called financial toxicity. And the level of financial toxicity depends on multiple factors, including access to insurance, gender, age, being part of minority groups, previous debts, less income, and the cancer treatment affects the patient's ability to work. So especially younger patients, they could be affected when they have the cancer diagnosis. Sometimes their family rely on their income, and these affect not only the patient but the whole family. So, and how can financial toxicity affect the patient? So, there are studies suggesting that patients who have more financial toxicity, they have worse survivals, they definitely have lower quality of life, and sometimes these patients might not take their medications as prescribed, especially when they don't have insurance or they have a co-payment insurance, so they don't have money to afford the medications. And sometimes they will not go for their blood work, chemotherapy appointments, given the price of the gas, parking lot, and travels. And when we think about Canada, we think, oh, we might not have financial toxicity as much as United States or other countries because we are in a public healthcare system. But there's been a lot of research done in Canada when it comes to financial toxicity. And to start with, 37% of our patients in Canada, they have already some financial difficulty. And the financial difficulty in different studies were associated with worse survival. And not all the provinces are the same. So the coverage of drugs and cancer treatment is not universal. So each province has different, the patients have different access to cancer drugs or supportive care drugs like anti-nausea pills. So Saskatchewan, for example, they have a very good coverage. 94% of the cancer drugs are covered there, whereas in PI only 64%. 60% of the Canadians have private insurance, so 40% of the patients don't have private insurance. And out of pocket expenses include gas, parking, hotels, drugs, insurance. So it's not only about drugs, everything that comes with the cancer treatment can be very costly for the patients. Uh, this is so we don't have this data in New Brunswick about financial toxicity. So this will be actually the first study being done in the Atlantic, Canada, when it comes to financial toxicity. So we had this idea to address this issue within our network at Vitalité. And our objective with this study is to evaluate the patient reported financial burden of cancer treatment, examine the impact of financial burden in quality of life, and try to analyze correlations between financial toxicity, socio-demographic characteristics, and treatment factors. So this is a pilot cross-section observation study. We included individuals that are adults, 18 years old or more, who have received a diagnosis of cancer, who are on active surveillance or active treatment. And these patients could be enrolled if they are seen by the GPOs, medical oncologists, hematologists, or radiation oncologists. They should be able to provide the informed consent, and they are asked to answer the survey voluntarily. So the social demographic characteristic in our questionnaire includes age, annual income, level of education, if they have private insurance or not, primary language, geographic location, race, sex, and gender identity. We also analyze the cancer type, the stage of the cancer, if it's palliative or curative intent treatment, if the patient had radiation, chemoradiation, or different types of treatment. In the end of this questionnaire, there is a validated financial toxicity survey and a validated quality of life survey. We aim to enroll 175 participants. In order to do all the analysis, we're going to use an alpha of 0.05. to analyze the significance of the multivariable findings. We assume that 20% of the patients will have incomplete data. So we aim to recruit more than 175 patients. We want to recruit at least 125. And again, this was approved by the REB, and this is voluntary and anonymous. So this questionnaire provides minimal risk associated with this study. So today we're gonna present the preliminary results of our questionnaires, and although again it's not the number we were again, we just started this study, but we were able to find very interesting findings with these 69 patients. So we found that 36% of the patients, they had high income. We defined high income as having a income more than $80,000. So the majority of our patients, they have a low income, low and middle income, less than 80,000. So almost 70%. What was surprising is that 84% had access to health insurance. Moving forward, we're gonna try to determine it if they have private health insurance or the New Brunswick drug plan, because I think not necessarily 84% of them have private insurance. And 44% of these patients were highly educated, so they went to university or college degrees, and 50% of our patients were 65-year-old or more. And then we did some correlation between financial toxicity severity and multiple factors. So I'm going to be presenting them to you. So when we look at income alone, just income as a unique factor, patients who had high income compared to low income, they didn't have increased financial toxicity. However, we have some hypotheses for that. One of them is because, again, 84% of the patients, they have access to insurance. And maybe when we look at income as a unique thing, maybe we should be trying to look at a different way. So for example, sometimes patients with high income, they have a lot of debts, and so not necessarily the income itself is related to financial burden or not. And there's something called financial resilience that I learned with Dominique, who helped me. Thank you, Dominique, for helping me with these graphs and analysis. And sometimes the patients can have low and middle income, but they have more resilience to save money. So we're gonna do some modifications moving forward to see if we can be more precise, instead of looking at the income alone, to add other variables to try to understand the relationship with financial toxicity, including financial resilience, if the patients have debts and things like that. Now, when we look at the health insurance, the patients who had health insurance compared to those who didn't have, so 84 versus 16%. Now, we did see an increase of financial toxicity severity in those who doesn't have insurance. So when they don't have insurance, they do struggle financially. And all of the patients who didn't have insurance, they were part of the low and middle income household. This was statistically significant. So health insurance does impact in financial toxicity. When we look at the differences between cis men and cis women, we see that cis women were less likely to have high income compared to men, so they tend to be more low and middle income compared to men, that they can have more, in percentage wise, more high income. And when we look at the financial toxicity in women with low and middle income, they have more financial toxicity than men. Now, when we look at so with this analysis in terms of gender, we didn't have any transgender patients. So, but in different studies, we can see that transgender people, they tend to have more financial burden as well. In terms of minority and racialized groups, 19% of the patients were part of minority groups, whereas 81% were not. And all of them were the patients who were part of the minority groups, they had low income. When we look at the financial toxicity in this population with part of minority groups, they had increased financial toxicity severity compared to the group that was not part, that were non-minorities. When it comes to age, this was very interesting, and that's what we see in our clinics frequently. Patients who were younger, so younger you are, you can see here at the financial toxicity severity. Younger you are, you can have more financial toxicity. And this is basically because younger patients, they have more income instability, less saving, less insurance coverage, and often they need to stop working to dedicate their lives to the cancer treatment. So younger patients seems to have higher risk of financial burden. Now, when we combine different factors, so let's say we combine age and gender, or gender and being part of a minority group. So when you have one or more risk factors, you can see the financial toxicity severity increasing. So maybe having one single factor, you might not be in higher risk, but when you have one factor or more, including age, being part of minority, access to insurance, so more risk factors you have, more likely you have to struggle financially. When we ask the patients if they had to modify their finances due to the cancer treatment and cancer diagnosis, 61% of the patients, they had to modify their finances. And we see that patients who had low and middle income, they had to modify their financials even more than those who had high income. And I think over all the data we have, this was the one that I was more impressed about, is that in 74% of the cases, financial resources were not discussed with patients. So we, as medical oncologists, I don't think we are addressing this issue as we should. And we are not offering the patients the financial resources that are out there. And when we look at the quality of life, the relationship between financial toxicity and quality of life, one of the domains in the quality of life survey that we used is the environmental domains. And in this domain, it captures the financial resources, physical safety, and security. And there was inversely correlated quality of life with financial toxicity, meaning that more financial toxicity you have, less quality of life you have, especially when it comes to the environmental domain. So moving forward, we want to do some modifications, hopefully with the questionnaire, and try to understand a little bit more of the financial resilience, not only the income, and try to correlate that with financial toxicity. We also did some analysis in terms of which treatment the patients were having and what type of cancer they had. So there was a very good balance between solid tumors, hematologic, patients on radiation or chemo. So we are able to capture a lot of different populations. And pretty much 50% were curative intent and another 50% were palliative. We didn't analyze this time the financial toxicity in the palliative care setting compared to the curative, but hopefully in the future we'll do that. So to conclude, having no health insurance, we saw increase in financial toxicity. Cis women were less likely to have high income compared to cis men, and there was a tendency increase financial toxicity for women. All of racialized and minority groups had a low income, and consequently, they also had increased financial toxicity. Younger patients, they had also increased risk of financial burden. And when you combine those factors, you can see an increased risk of financial toxicity. This is an issue, it's clear, but not necessarily we've been addressing this issue properly. And what we hope with this study is to provide some data. So this would be the first study addressing this issue in New Brunswick and Atlantic Canada. We want with this study to provide awareness of financial toxicity in the cancer patient's journey. And hopefully by identifying those patients, we could maybe have better screening tools. In some studies, there are some EMR system, they detect patients by the time you see them if they are in a high risk of financial toxicity. So maybe it's something to have in the future. And also to, I think, by creating awareness and having some data, we'll be able to provide some education to us, medical oncologists and oncology staff. And also, we hope to collaborate with social workers and see what kind of resources there are available for these patients. How can we use them and benefit for them? And so hopefully with this study, we'll be able to have everything that I listed. So lastly but not least, I just want to thank the team that has been working with me. And honestly, without them, this wouldn't be done because they know how busy I am. So they did pretty much everything. So thank you, Dominique, Nadia, Tina, Shirko, all the medical students, and all of my colleagues who are helping me to recruit these patients in this study. So thank you so much for the help so far.
Awesome. Thank you, Dr. Megid, for this great presentation. Really, really interesting stuff. We already have, I think I saw some hands come up, a lot of emotion, a lot of people clapping. I will open the floor to the questions. So if you have a question, please raise your hand and open your mic if you can, and your camera if you can. So we have a lineup of questions here. Let's go with Julie Arsenault first.
Allô, est-ce que vous m'entendez?
Oui.
Super. Thank you, Thais. That was a wonderful talk. It's very exciting to see this work being done and very important as well. One little thought I had while you were doing your presentation, and maybe that's just sort of a follow-up thing or for down the road. You had mentioned social workers, but I also thought of the new role we have with nurse navigators, les infirmières pivots. And it would be interesting to look at this aspect, and involvement. So for patients that have early involvement of a nurse navigator, is there better access to financial resources than others? It's a relatively new role, and it's something we could potentially look at. Whether having them involved early on helps with some of the burden or not. But otherwise, the work obviously is very important and interesting, and I look forward to seeing where this goes.
Thank you, Julie. I'm just taking notes as you speak because I think they are very important. Like we are very lucky to have them. I don't know if I'm not using them for that, but it would be important. They would be so helpful for that. Thank you for your comment.
Even I know right now that's, it's sort of a self-referral program, and or we can refer patients when we want, but if ever the resource became, I guess, available enough, whether reflex referral might help alleviate some of those burdens, financial included, I guess.
Thank you. So I guess Dr. Saint-Hilaire, Dr. Finn, thank you for joining. I think Dr. Finn first.
Yeah, I can start.
Ladies first, but I can see your yeah.
I don't obey that rule. It's more of a comment, I guess, that when I noticed something upon trying to recruit the patients that could sometimes falsify the data. So there's patients I would like to recruit that, you show them a QR code or you show them a website, you show them, and they kind of take out a flip phone, or they actually have no cell phone, so I have a hunch that there's a population of the ones who actually have the least financial means we're having a hard time recruiting. I've noticed that there's a selection of patients that unfortunately is happening when I'm trying to recruit these patients.
No, I think that's an excellent point because we also raised this question. We wonder if the patients who are more educated, who has more literacy, they will answer more the survey because of the level of that education, and whereas maybe patients who has less literacy and they might or not even a cell phone to scan the QR code. So there is a bias in that. So there is a chance we are not capturing the patients who are in higher toxicity. And one of the ways to overcome this barrier, and that's why we have the students, is they come and actually they will be by the patient side and they give the tablets. I mean, maybe we should have some paper as well printed, but for data collection, it's easier with the tablets because then it's easier to analyze the data. But I think we should have some printed. I think that's a good idea that we'll discuss. But I will write that down and we can discuss with the group. Thank you, Nicola. That's a great comment.
Thank you, Thais. I just want to make sure I understood. So you say the younger population have more financial toxicities than the older population. Is it what I understood?
Yes.
Okay. So do you ask them? I never saw the questionnaire, so I don't know exactly how deep you go into questions. But do you know? Do they have kids or like I don't know how to say that in English, like personne à charge? Like, are they in charge of somebody, like kids or spouse, or do they have a mortgage? Like how? Because it's the situation in your life when you are 35, you have certainly more financial responsibilities than when you are 75 and your house is paid and your kids are raised, right? Are you looking at these things?
So no, we don't have this question specifically, but so we are stopping the recruitment because and this presentation was good because your comments and ideas will help us to better define things. But maybe we should understand what role that patient plays in the house income. Sometimes if they are the provider, the main provider, there's a huge impact for the whole family. But yeah.
Because I think it's hard to see, is it just the cancer treatment and the cancer diagnostic that is causing them trouble, or is it just the phase in their life where they are? I don't know.
So in different studies, there's two extremes, like elderly patients who, their savings are not good enough because it's, they are in their 80s and 90s. And there is the other extreme, the younger population. Sometimes these patients are the main person in the house income. And both extremes in previous studies show these patients struggle more financially. Younger adults and elderly patients when they are in their 80s and 90s.
Okay, thank you.
Mathieu?
Yeah, thank you for the presentation. Really interesting. So this may sound more like a suggestion than a question, but you can take it the way you want it. One observation during the presentation is that you looked at various identities of individuals, such as their gender, their social identity, their age, and various factors like that. And those identities were looked at pretty much in single axis type analyses. And I wonder if you considered analyzing the various factors through the lens of potential overlapping identities. I feel as if much of those factors probably interact one with another, and
Yeah.
it may be more complex than a simple addition of one factor plus the other and so on. So I feel as if many of those factors are probably interlocking systems, and perhaps looking at this from a intersectional analysis perspective may be worthwhile in this context.
No, 100%. I'm sure there's a lot of overlapping. So I'm sure between races, gender, lack of insurance, sometimes these patients overlap the minority groups and everything. I think the numbers we have, it was only 69, so we couldn't do uh, uh, more detailed analysis. I think once we have 200 patients or more, we'll be able to differentiate more and see what overlaps or not. But with 69%, that's why some of the data we said it's somewhat we had a statistic significance a positivity, but some of them we just saw tendencies because the number was still very small to do more detailed analysis.
Yeah, I agree. So it will be interesting once you have even more participants in this cohort. Thank you.
Thank you.
Yeah, Dr. Megid, again, I commend you for the great work. This is not a topic that I'm very familiar with, but what's interesting for me is the numbers that you kind of presented, right? When you're saying 74% of the doctors don't discuss this with patients, what would it look like if they did discuss this with patients? So would it be different treatment options? Would it be different approaches? How does that conversation go, right? Because 25% of them are doing it, 3/4 of them aren't. And how does that conversation go with a patient? And again, I'm just trying to kind of inform on all this here.
So in our questionnaire, there's two things. There's a question where we ask if the doctors ever discussed financial issues with the patients. And the second question is, if so, if they offered financial resources like a social worker, or sometimes we help with the taxes forms and things. So there's two different questions. I don't think with this number that we had, we were able to answer these two questions separately. I think when it comes to financial toxicity, previous research talking about finances is to the patients, it's a bit embarrassing sometimes. So sometimes the patients they feel shy to discuss that with healthcare professionals. So in different studies, it shows like, so sometimes it needs to come from the doctor because the patients, it's the same thing talking about sexual dysfunction. Sometimes the patients feel shy to talk about that. So we should address that. And there was one data that I forgot to show, but when the patients have lower income in our analysis, we talk more about financial issues compared to those who have high income. So sometimes we assume that because the patient has some certain type of job that they don't struggle financially, but we should be addressing that with everyone because we see patients that didn't come to the appointment because the gas was expensive or the blood work. Sometimes they have to pay $15 for the blood work, and for some patients it can be a lot. So there was studies that showed that in Canada, depending on the province, the patients can spend between $200 to $1,000 per month with the cancer treatment, including drugs, parking lot. So depending on their income, it can be a lot, right? Dr. Saint-Hilaire?
Thank you.
I just want to make a comment because I think there's something in the perception of the patient. For example, for each patient we see, we ask them, do they have insurance? Is it private? Is it the provincial? How much is it covered? Do they have a copay? We ask them if they work, are they off work? Do they need any paper to, for their AI? So we do ask the questions. Of course, we are not social workers, so it's hard for us to suggest resources in the community because there's almost nothing, honestly, to help our patients. I don't think it's because we don't propose resources. I don't think there is enough resources. And then, so even if we ask all these questions, I'm not sure that the patient, when you will fill out the questionnaire, will say, oh, yes, Dr. Saint-Hilaire asked me about my financial toxicity. But I kind of did because I checked, are you working? No, you won't be able to work with your treatment. You need something for your AI. I'll put you in contact with the social worker. We do that, but I'm not sure the patients realize we are doing it. You know what I mean?
No, I understand. I agree with you. There's not enough resources, but I think there are resources that we are not aware. For example, um, there are some sort of help with gas, but I don't know, and that's why. But I didn't know until recently. But also, I'm not addressing this with all the patients unless they bring that up. So I I'm curious to know, like maybe if we identify who are the patients in higher risk, maybe we can be more proactive in that sense, offering before they bring that up. But it's really hard. It's really hard because sometimes uh, there's not enough resources, I find.
Yeah, and
But
I think
things
they are
like,
overwhelmed. They are overwhelmed with the diagnostic, with the difficulty to accept the prognostic, with the information about treatment. It's hard to assess what they remember from all the things we've addressed with them. So basically, it's just to see that I think there is a question of perception of the patient when they fill out the questionnaire. I'm not sure if they say, no, it wasn't addressed, that it is always true. That's what I think, yeah.
well, I will review how we can ask that, like more than yes or no, maybe to be more specific.
Give
Yeah.
examples of type of questions or things that could count into that. And also, I think when it's going to be final and you're going to have the results, it could even be something to make government change some policies, like the parking, for example. If you are a cancer patient in BC, you don't pay the parking in the hospital.
Yes.
So there are easy things like that can be done if we have numbers to show to the government. Yeah.
That's very good, Ev. Thank you.
Any more questions? Est-ce qu'il y a d'autres questions au Dr. Megid? Gone once, gone twice. No, I think we've covered We've covered it. Dr. Megid, thank you again for your time. Thank you for the richness of the conversations that we had afterwards as well. It's really a subject that, it's not like you mentioned, it's not something that we always think about when we talk about cancer and prognosis and things that are happening. So thank you for shedding light on this. Merci à tout le monde d'être venu. Merci d'avoir participé aux conférences mensuelles. La présentation du docteur Megid sera mise en ligne par la suite où vous aurez accès donc pour soit la regarder, la diffuser et garder un œil ouvert sur la prochaine conférence du mois de février venant du Centre de formation médicale. Donc, encore une fois, merci beaucoup à vous tous et bonne journée.
Merci beaucoup. Bye bye.